Okay, so in this video we're going to discuss about diuretics. Diuretics are drugs that increase the rate of urine flow, and even though diuretics are usually discussed in pharmacology textbooks under the chapter renal system, it is my personal opinion that diuretics are better understood when dealt with in the context of the cardiovascular system. This is because diuretics form the mainstay of treatment in many important cardiovascular disorders. Now this is a picture of the nephron, and we shall now see the various regions of the nephron as relevant from the point of view of a discussion on diuretics. So this would be the proximal convoluted tubule. That would be the thick ascending limb of the loop of Henle. This would be the distal convoluted tubule. This would be the collecting duct. In addition to these regions, we should also consider the loop of Henle as a whole, because when we discuss diuretics, the diuretics that we discuss act on each of these regions. Diuretics that act on the proximal convoluted tubule are the carbonic anhydrase inhibitors. Diuretics that act at the thick ascending limb of the loop of Henle are called the loop diuretics. Those which act in the distal convoluted tubule are called thiazide diuretics, while those that act at the collecting duct spare potassium. They leave potassium alone, and therefore they are called potassium-sparing diuretics. These include the epithelial sodium channel blockers, or ENaC blockers, and mineralocorticoid receptor antagonists. The examples for ENaC channel blockers include amiloride and triamterene, while the examples for mineralocorticoid receptor antagonists include spironolactone and eplerenone. The diuretic that acts at the loop of Henle are the osmotic diuretics. So these are the diuretics that we shall discuss in this particular discussion. It is important for us to remember that all diuretics except potassium-sparing diuretics will increase the urinary excretion of potassium. Now throughout this discussion, what we will do is that we are going to discuss first what happens normally. We will discuss the normal physiology that occurs at each of these points in the proximal convoluted tubule, in the thick ascending limb of the loop of Henle, the proximal convoluted tubule, and so on. We will discuss the normal physiology in each region first, and then we will go on and discuss what happens when we add a diuretic in that particular point. Right, so let's now discuss the normal physiology in the proximal convoluted tubule. So this would be the proximal convoluted tubule, and this is the region that we are going to discuss now. So that's the lumen of the proximal convoluted tubule, and this is an epithelial cell that lines it. On the basolateral aspect lies a capillary. Now, the basolateral aspect of this cell contains a pump, and it is called the sodium-potassium ATPase pump. It pumps 3 sodium ions out of the cell and 2 potassium ions into the cell. Now there are 3 ions that we need to consider in the proximal convoluted tubule, and they include sodium, bicarbonate, and chloride. We shall see what happens to each one of these ions normally in the normal physiology that occurs in this particular part of the nephron. Now as far as sodium is concerned, sodium moves from the lumen into the cell via a pump. It is an antiporter or an exchanger. It is the sodium-hydrogen exchanger. So when sodium moves into the cell, hydrogen ions are pumped out of the cell and into the lumen. Right. The sodium that ends up inside the cell gets thrown out of the cell via the basolateral aspect, via the sodium-potassium ATPase pump and other pumps that we shall see later. So in this way, sodium is conserved or reabsorbed from the proximal convoluted tubule. Next we move on to bicarbonate. So bicarbonate combines with the H+, which has now reached the lumen, and forms carbonic acid. The carbonic acid thus formed spontaneously decomposes. Well, not really spontaneously, it decomposes in the presence of an enzyme, and that enzyme is carbonic anhydrase. So it decomposes into carbon dioxide and water. And since carbon dioxide is extremely lipid soluble, it easily diffuses into the cell. Now, all cells contain water, and therefore carbon dioxide will combine with this water and form, or rather reform, carbonic acid in the presence of cellular carbonic anhydrase enzyme. The carbonic acid then splits up into H+ ions, the fate of which we just discussed, and bicarbonate ions. The bicarbonate ions move in the opposite direction from the cell to the capillaries via the basolateral aspect. So in this way, the second ion, namely bicarbonate, is also reabsorbed from the proximal convoluted tubule. The reabsorption of bicarbonate ion via the basolateral aspect of this cell occurs via a pump. It is a symporter, the sodium bicarbonate symporter. So this is yet another way in which sodium is also reabsorbed from the proximal convoluted tubule into the capillaries. Now, as a result of all these ionic changes, chloride tends to move from the lumen of the proximal convoluted tubule to the capillaries via the spaces between the cells, and this is what we call the paracellular pathway. Right, so this explains the normal sequence of events that we would expect to occur in the proximal convoluted tubule. Now, what would happen if we administered a carbonic anhydrase inhibitor? So what would happen to each one of these ions, sodium, bicarbonate and chloride? Well, if we administer a carbonic anhydrase inhibitor, obviously the subsequent steps do not happen. Carbonic acid fails to decompose into carbon dioxide and water. There is failure of regeneration of carbonic acid within the epithelial cell that lines the proximal convoluted tubule. There is failure of breakdown of this carbonic acid into H+ ions and bicarbonate ions. Since H+ ions are not available to drive the sodium hydrogen exchanger, sodium fails to move from the lumen of the tubule into the cell, and sodium is lost in the urine. We know that wherever sodium goes, water follows. So sodium is lost in the urine. Secondly, because the cellular carbonic acid fails to get formed, bicarbonate fails to move from the cell into the capillary, and therefore bicarbonate remains in the tubular lumen and gets lost in the urine. So there goes sodium and water, there goes bicarbonate. And again, because of the failure of reabsorption of these ions, chloride is also lost in the tubular fluid. Therefore, the administration of a carbonic anhydrase inhibitor would increase the urinary excretion of sodium and therefore water. It would increase the urinary excretion of bicarbonate and therefore result in metabolic acidosis. It would also increase the urinary excretion of chloride. Now, since this is not a potassium-sparing diuretic, it will also increase the urinary excretion of potassium. Right. Now, what are the clinical uses of carbonic anhydrase inhibitors? Well, as diuretics, they happen to be very weak, and therefore they may not be very useful clinically as diuretics. However, there are situations where carbonic anhydrase inhibitors find very important clinical utility, and they include situations where we would want to produce mild metabolic acidosis and situations where we want to inhibit the production of various body fluids that require carbonic anhydrase enzyme for their production. These include body fluids like aqueous humor and cerebrospinal fluid. So, the common indications of carbonic anhydrase inhibitors would be those that involve the production of mild metabolic acidosis and those which involve the inhibition of production of body fluids which require carbonic anhydrase. So what are the situations where we would want to produce mild metabolic acidosis? Well, obviously one would be metabolic alkalosis. So that's one situation. Another situation where we would want to create a mild metabolic acidosis is in the prophylaxis of mountain sickness. Right. Since carbonic anhydrase is required in the production of body fluids such as aqueous humor and cerebrospinal fluid, it's logical to think that carbonic anhydrase inhibitors would find clinical utility in situations such as glaucoma and hydrocephalus. The most important example of a carbonic anhydrase inhibitor is acetazolamide, a systemically administered and systemically acting carbonic anhydrase inhibitor. However, there are other carbonic anhydrase inhibitors with more action in the eye with little systemic effects. These are classified into two, those which are given topically and those which are given orally. Those which are given topically include brinzolamide and dorzolamide, while those which are given orally include methazolamide. Right. There are certain contraindications of carbonic anhydrase inhibitors that need to be kept in mind. Those with a previous history of sulfur drug allergy are, these patients are best avoided. We should not give these patients carbonic anhydrase inhibitors. Patients with hepatic encephalopathy should not receive carbonic anhydrase inhibitors, and patients with history of calcium phosphate stones, these patients should not receive carbonic anhydrase inhibitors. Right, so now let's move on to the normal physiology in the thick ascending limb of the loop of Henle, which would be this particular region that you see right here. Okay, so there's the lumen of the thick ascending limb. There is a epithelial cell, there is one epithelial cell and there's another one lining the lumen of the thick ascending limb, and on the basolateral aspect, as you can see, is a capillary. As always, on the basolateral aspect of this cell, we find the sodium-potassium ATPase pump, which pumps 3 sodium ions out of the cell and 2 potassium ions into the cell. Now, on the luminal aspect of this cell is a symporter. This symporter is the sodium-potassium 2-chloride symporter. It pumps sodium, potassium and chloride from the lumen of the thick ascending limb into the cell. As you can imagine, the sodium which is pumped into the cell moves from the cell to the capillary via the sodium-potassium ATPase pump. The chloride ions which are pumped into the cell via the sodium-potassium 2-chloride symporter end up in the capillary via a transporter. Now, as you can see, potassium is entering the cell both via the basolateral aspect as well as the luminal aspect. This is a lot of potassium. All this potassium is allowed to leak out of the cell and into the tubular lumen via a transporter called the Röhm-K transporter, and the net result is plenty of positive charges in this particular region of the nephron. Now, what does this result in? When positive divalent ions, when divalent cations like calcium and magnesium get filtered and they reach the thick ascending limb, they encounter plenty of positive charges over here. There is a powerful repelling effect, and these ions tend to get reabsorbed via the spaces between the cells called the paracellular pathway, and they end up back in the blood. So this would be the normal sequence of events in the thick ascending limb of the loop of Henle. Now, what would we expect if we were to block the sodium-potassium 2-chloride symporter? Well, obviously, we would expect an increase in the urinary excretion of sodium and therefore water, potassium, chloride, and yes, calcium as well as magnesium. Yeah. Drugs acting at this particular site are called the loop diuretics. Now, it's very well known that loop diuretics are the ones with the highest efficacy, and since the maximum possible response is sometimes referred to as the sealing effect, these diuretics are also called high sealing diuretics. Loop diuretics can be classified into 3 depending on their chemical structure. Some loop diuretics have got a sulfonamide structure, and these include the prototypical loop diuretic, namely furosemide, also called furosemide. The other example for this loop diuretic would be bumetanide. Now, sulfonylurea loop diuretics include torsemide, and there are other loop diuretics, an important example of which is ethacrynic acid. At this juncture, I would like to warn you that ethacrynic acid is completely different from ethacridine lactate. That is something completely different, which will be dealt with in far greater detail in the obstetrics and gynecology classes. Now, there are many indications for loop diuretics, the most important one of which would be heart failure, particularly heart failure with reduced ejection fraction. There will be detailed lectures on heart failure later, and we shall see there that loop diuretics are very, very important drugs in the management of heart failure with reduced ejection fraction. Later, in lectures on hypertension, we shall see that loop diuretics have a very minor role to play in hypertension. They are not considered as first-line drugs in hypertension. They are very well considered as second-line drugs in the treatment of hypertension, and they are useful only in a couple of situations of hypertensive patients. Loop diuretics are useful in the treatment of edema of various causes, and they can be life-saving in patients with acute pulmonary edema, which we commonly see in association with acute decompensated heart failure. There are certain forms of hypercalcemia that can be treated using loop diuretics. Certain patients do benefit from the administration of loop diuretics, patients with hypercalcemia. So these are some indications. Right, so just to briefly tell you about the role of loop diuretics in heart failure. There is a form of heart failure called chronic compensated heart failure, where the patient is relatively asymptomatic. In such forms of heart failure, loop diuretics are given orally, and in such patients, loop diuretics act by reducing the extracellular fluid volume, thereby relieving congestive symptoms. The congestive symptoms in the pulmonary circulation and the peripheral circulation as well. However, when we talk about heart failure in the acute decompensated form, where the patient suffers from pulmonary edema, loop diuretics need to be given in the intravenous route. Now, when we give loop diuretics via the intravenous route, the mechanism is different. The mechanism of loop diuretics here, in this particular situation, is to increase venous capacitance. In other words, venodilatation. That is the mechanism of action of a loop diuretic in the management of acute decompensated heart failure with pulmonary edema. Of course, reduction of extracellular fluid volume with brisk natriuresis also occurs, but the primary mechanism in acute decompensated heart failure is definitely venodilatation. This results in rapid relief of acute pulmonary edema. As we mentioned, loop diuretics have got a very minor role in the treatment of hypertension. They do become useful in two particular situations, namely, if the patient has got hypertension and renal failure as well, with a GFR of less than 30, or if the patient is hypertensive and has got symptomatic heart failure as well. So in these conditions, loop diuretics become important antihypertensive agents. Now, in addition to the many electrolyte imbalances that loop diuretics can produce, loop diuretics, when administered chronically, can increase the resistance to the action of insulin, and therefore these drugs have been implicated in situations such as hyperglycemia, dyslipidemia, and hyperuricemia. All these are conditions which are closely associated with increased insulin resistance. Right, so now we move on to the distal convoluted tubule, and as always, let us see what happens normally. let's take a look at the normal physiology in the distal convoluted tubule. So that would be the region where we are looking at. So there's the lumen, and here's the epithelial cell that lines the distal convoluted tubule, and there is a capillary on the basolateral aspect. As always, we have the sodium-potassium ATPase pump on the basolateral aspect of the cell, which pumps 3 sodium ions out of the cell and 2 potassium ions into the cell. Now, on the luminal aspect of this cell, we have a symporter. The symporter is a sodium chloride symporter. Now, the chloride ions that enter the cell are allowed to leave the cell via a transporter. So there goes chloride. Of course, the sodium that enters the cell is pumped out via the sodium-potassium ATPase pump. The chloride that enters is then allowed to leak out of the cell via the chloride transporter. Now, in addition to both these, there is one more transporter which is seen on the basolateral aspect of this cell, which is of importance. And this is the NCX, or the sodium-calcium exchanger. The sodium-calcium exchanger is under the influence of a receptor, and that receptor is the parathormone receptor. When this receptor is stimulated by parathormone, the NCX is going to work more efficiently, and it pumps calcium ions out of the cell, and sodium ions are pumped in the opposite direction. When this happens, the intracellular levels of calcium falls. To compensate for this, there is a transporter on the luminal aspect of this cell, and it allows calcium to enter the cell. So this explains the normal physiology that occurs in the distal convoluted tubule of the nephron. Now, what would happen if we were to block the sodium chloride symporter? Now, if we were to block the sodium chloride symporter, sodium fails to enter the cell. But this is not going to prevent the sodium-potassium ATPase pump from working. It will continue to throw sodium out of the cell, and this would result in a fall in the intracellular levels of sodium. To compensate for this, the sodium-calcium exchanger will undergo upregulation. It is going to pump more sodium ions into the cell, and when it does this, it will have to pump calcium in the opposite direction. This results in a fall in the intracellular levels of calcium. And to compensate for this, the transporter for calcium on the luminal aspect is also going to upregulate, and it is going to allow more calcium to enter the cell from the lumen. Therefore, the net result of the administration of a thiazide diuretic, which are the diuretics that block the sodium chloride symporter, the net effect of the administration of a thiazide diuretic would be increased urinary excretion of sodium, chloride, but decreased urinary excretion of calcium. So the administration of thiazide diuretics would actually cause increased reabsorption of calcium. So that's the difference between a thiazide diuretic and a loop diuretic. A loop diuretic would waste calcium in the urine, while a thiazide diuretic would actually result in increased conservation of calcium. Right. So we need to know the thiazide and thiazide-like diuretics. They include Chlorthalidone, by far the most important example, chlorothiazide, hydrochlorothiazide, indapamide, and metolazone. Now, by far, the most important clinical utility of thiazide diuretics is in the treatment of hypertension. They are considered among the first-line drugs in the management of hypertension. In fact, among all antihypertensive drugs, chlorthalidone may be considered as an optimal choice for the first step drug therapy in hypertension. There are two reasons for this. Number one, hypertension is a lifelong disease and patients need to be treated lifelong. It makes little sense if you were to prescribe this patient a drug that needs to be taken 3 times a day or 4 times a day, lifelong. You prefer a drug with a long T half that can be given once a day. Chlorthalidone fulfills this criteria. Secondly, the evidence, the high quality evidence that supports the view that chlorthalidone reduces the risk of future cardiovascular disease as a result of hypertension is very, very high. There is a large body of evidence that supports this claim. Due to these reasons, chlorthalidone is considered the optimal choice for first step drug therapy in the treatment of hypertension. Now, we discussed the mechanism of action of thiazide diuretics as an inhibitor of the sodium chloride symporter, but how exactly does it act as an antihypertensive drug? The answer to this question is vasodilatation. So just as how loop diuretics are beneficial in acute decompensated heart failure by producing venodilatation, thiazide diuretics are useful in hypertension by producing vasodilatation. The mechanism of this vasodilatation is still under debate. There are various theories, but none have gained considerable acceptance. Now, when used as monotherapy, the maximal daily dose of hydrochlorothiazide or chlorthalidone should not exceed 25 milligrams. This is because doses in excess of 25 milligrams will not reduce the blood pressure further. All they will do is increase diuresis. So, if adequate blood pressure reduction is not achieved with a 25 milligram daily dose of hydrochlorothiazide or chlorthalidone, what do? Do we increase the dose or do we add another antihypertensive agent? Well, the answer should be obvious. We add another antihypertensive agent. Now, which antihypertensive agent would that be? Well, thiazides cause potassium loss, and therefore it's logical to add another antihypertensive agent that would conserve potassium. The obvious choice would be AC inhibitors or angiotensin receptor blockers. So they may be added to thiazide diuretics if the blood pressure fails to be controlled with a daily dose of 25 milligrams of either hydrochlorothiazide or chlorthalidone. Having said that, thiazides and related diuretic agents increase the efficacy of virtually all other antihypertensive drugs. Now, thiazide diuretics may not work in patients with renal failure, especially if the GFR falls to values below 30. But there is one exception to this rule, and that is metolazone. Now, we need to remember that most patients respond to thiazide diuretics with a reduction in blood pressure within 1 to 1.5 months, 4 to 6 weeks, and therefore doses should be titrated only after 4 to 6 weeks. It makes little sense to increase or decrease the dose before then. Right. Now we come to the potassium sparing diuretics. As we discussed earlier, the potassium sparing diuretics may be classified broadly into two: the epithelial sodium channel blockers and the mineralocorticoid receptor antagonists. Let us take a closer look at the mineralocorticoid receptor antagonists first. Now, right off the bat, we need to understand that all diuretics require access to the tubular lumen in order to induce diuresis. But there is an exception, and the exception are the mineralocorticoid receptor antagonists. They are the only diuretics, they are the only class of diuretics that do not require access to the tubular lumen to induce diuresis. Now, mineralocorticoid receptor antagonists can be classified broadly into two. They include those with additional properties at other receptors. The most important example of such mineralocorticoid receptor antagonists would be spironolactone. There are other mineralocorticoid receptor antagonists that do not have additional properties at other receptors. These are selective mineralocorticoid receptor antagonists. The example would be eplerenone. Now, after all, these are mineralocorticoid receptor antagonists. So, let us now first discuss what mineralocorticoids normally do, and then we shall try to understand what happens when we block a mineralocorticoid receptor. So, we know that mineralocorticoids are released from the cortex of the adrenal gland. So the mineralocorticoid that we are talking about, the endogenous mineralocorticoid that we are talking about, is obviously aldosterone. Now, aldosterone has got multiple targets. One would be the cardiac myocyte, and we shall talk about this in great detail when we speak about heart failure. But for now, we shall focus our attention on the second target of aldosterone, which is the epithelial cells that line the collecting duct. So what you see in blue is an epithelial cell that lines the collecting duct, which are represented by the black lines over there. Now, like any other cell, an epithelial cell that lines the collecting duct contains a nucleus and a cytoplasm. The nucleus contains DNA. Now, in the unliganded state, or in the absence of aldosterone, the receptor for aldosterone exists in the cytoplasm. Aldosterone binds to this receptor and produces a complex, and this complex gets translocated into the nucleus and stimulates genes which undergo transcription and translation to produce two types of proteins. One of these proteins gets inserted into the luminal aspect of the epithelial cell that lines the collecting duct, and this is nothing but the epithelial sodium channel, or ENaC. This channel allows sodium to move from the lumen of the collecting duct into the epithelial cell. The second protein that is produced is the sodium-potassium ATPase pump, which obviously pumps 3 sodium ions out of the cell and 2 potassium ions into the cell. So the sodium that moves from the lumen via ENaC ultimately reaches the circulation via the sodium-potassium ATPase pump, and we know that wherever sodium goes, water follows. The potassium that enters the cell ultimately leaks out into the lumen of the collecting duct via the potassium channels. Right, so all of this began when the zona glomerulosa of the adrenal cortex began secreting aldosterone. But from where does the cortex get the instructions to release aldosterone? Well, to understand this, we need to remember that the liver produces a very inactive product known as angiotensinogen, and as long as nothing happens, angiotensinogen remains in the plasma and does nothing. But whenever there is a fall in the extracellular fluid volume, there is an increase in central sympathetic outflow as a result of stimulation of the vasomotor center. The central sympathetic outflow will somehow try to restore extracellular fluid volume. It will do this by multiple mechanisms. It will try to maximize vasoconstriction. It will try to make the heart beat harder and faster, and it will cause the stimulation of beta-1 receptors in the juxtaglomerular apparatus of the kidney, and this would cause the release of renin. Renin will cleave angiotensinogen and convert it to angiotensin 1. Angiotensin 1 then proceeds to get converted to angiotensin 2 in the presence of an enzyme called the angiotensin converting enzyme. Angiotensin 2 then binds to its receptors called AT-1 receptors, which are present in multiple locations, one of which includes the zona glomerulosa of the adrenal cortex. So this is the full picture of the renin, angiotensin, aldosterone axis. Right. So what would happen if we administered a drug that blocks the mineralocorticoid receptor? Well, if we did that, then there would be failure of upregulation of ENaC channels on the luminal aspect of this cell. So sodium fails to move from the lumen of the collecting duct into the cell. This sodium, together with water, gets wasted in the urine. Also, on the basolateral aspect of the cell, there is failure of upregulation of sodium-potassium ATPase pump, and therefore potassium does not get pumped from the capillary into the cell. Potassium stays in the capillaries. Potassium is left alone. Potassium is spared. So, when we administer a mineralocorticoid receptor antagonist, it does increase the urinary excretion of sodium and therefore water, but it does not increase the urinary excretion of potassium. In fact, it spares potassium and it will increase the retention of potassium. Right. So regarding mineralocorticoid receptor antagonists, we said that there are mineralocorticoid receptor antagonists with additional properties at other receptors, the example of which is spironolactone, and there are selective mineralocorticoid receptor antagonists, the example of which is eplerenone. Now let us take a closer look at spironolactone and see what sort of effects it has at other receptors. So we said that at the mineralocorticoid receptor, it acts as an antagonist, but it does have unique properties at the androgen receptor as well as at the progesterone receptor. Now, because it has got antagonistic effects at the mineralocorticoid receptor, spironolactone is useful in the treatment of heart failure, especially heart failure with reduced ejection fraction. Because it antagonizes mineralocorticoid receptors, it is useful in the treatment of hypertension, especially resistant hypertension, which is associated with primary hyperaldosteronism. Because spironolactone blocks mineralocorticoid receptors, it is also useful in the treatment of edema, especially edema that is associated with secondary hyperaldosteronism. And we shall see a little bit more about this. Now, regarding the use of spironolactone in heart failure, we shall see more about this in lectures about heart failure. But I shall discuss very briefly the role of spironolactone in hypertension. Now, there are two reasons why spironolactone is useful in hypertension. Firstly, most patients treated with hypertension are treated with potassium wasting diuretics and are at higher risk of developing hypokalemia. The addition of spironolactone to these patients can ameliorate this risk. On the other hand, there are patients who develop resistant hypertension due to primary hyperaldosteronism, the most common causes of which are bilateral adrenal hyperplasia and adrenal adenomas. So these sort of patients would benefit greatly with the addition of spironolactone. So that's the role of spironolactone in hypertension. Now regarding edema, secondary hyperaldosteronism may result due to conditions such as cardiac failure, cirrhosis, nephrotic syndrome, ascites, and so on. So all these conditions are associated with edema. Now the administration of spironolactone would be very useful for the control of edema due to these causes. In fact, spironolactone is considered the diuretic of choice in patients with hepatic cirrhosis. Okay, so these indications, heart failure, hypertension, and edema, may be explained by the action of spironolactone on the mineralocorticoid receptors. There are two other indications of spironolactone that can be explained by its effect on the androgen receptors, and they are hirsutism and acne. So what are the unique effects of spironolactone on the androgen receptors? Well, we need to remember that spironolactone is a partial agonist at the androgen receptor, This would mean that if the androgen levels are low, then spironolactone would act as an agonist with submaximal activity at the androgen receptors. But if the androgen levels are high, then spironolactone would act as an antagonist at the androgen receptors. Now, which are the conditions where androgen levels are high? Well, physiologically, androgen levels are high in patients who are males. Administration of spironolactone to males can lead to conditions like erectile dysfunction and gynecomastia. Now, in females, there are some females who unfortunately develop hyperandrogenic situations. Spironolactone may be beneficial in some of those hyperandrogenic conditions, but not all. Now, there are many hyperandrogenic conditions, but as I mentioned, spironolactone are not beneficial in all of them. For example, spironolactone has no role in the treatment of, say, carcinoma endometrium or carcinoma prostate. However, spironolactone does have clinical utility in the treatment of hirsutism and acne. So this is explained by the fact that spironolactone is not an out-and-out androgen receptor blocker. It is more of a partial agonist and therefore may not be useful in all hyperandrogenic conditions. But yes, it does have some clinical utility in conditions like hirsutism and acne. Now we come to the unique effect of spironolactone at the progesterone receptors. Now, chemically, spironolactone is a progesterone derivative and therefore it does retain some of the effects of progesterone. And this explains why spironolactone can cause adverse effects like mastodynia and disturbances in the menstrual cycle in some females. So, this slide explains the various effects of spironolactone on the basis of the receptors and the action spironolactone produces on the various receptors that it acts upon. Right. Now, the adverse effects of spironolactone can also be explained on the basis of its effects on the various receptors. We know that spironolactone is an antagonist at the mineralocorticoid receptor, a partial agonist at the androgen receptor, and has got weak progesterone-like effect. Now, because it is a mineralocorticoid receptor antagonist, spironolactone can cause hyperkalemia. It can retain potassium and cause hyperkalemia, and this is by far the most important adverse effect of spironolactone. It is a life-threatening adverse effect and is potentially fatal. Because of its androgen receptor partial agonism, spironolactone can cause conditions like erectile dysfunction and gynecomastia in males. And because of its weak progesterone-like effect, it can cause mastodynia and disturbances in the menstrual cycle in females. Right, next we move on to the ENaC channel blockers, amiloride and triamterene. We know that most diuretics cause wasting of potassium and therefore these patients are at risk of developing hypokalemia. To reduce the risk of hypokalemia, an anti-diuretic drug may be added, and this is the most important indication of ENaC blockers. ENaC blockers like amiloride and triamterene are employed almost exclusively for their anti-diuretic effects. Right, finally we come to the osmotic diuretics. This is a rude and crude representation of the kidney, which I have turned to one side. You can see the cortex and the medulla. And now I need you to understand how nephrons are anatomically arranged within the kidney. Now, most nephrons are arranged such that the Bowman's capsule is seen in the cortex. The loop of Henle then descends into the medulla. It descends into the medulla, and the loop of Henle then turns within the medulla, and the ascending thin limb then moves out of the medulla towards the cortex. The thick ascending limb then penetrates the cortex, where the distal convoluted tubule is also present, and then the collecting duct dips again into the medulla and moves towards the renal pelvis, where urine is formed, and urine is then drained into the ureters. The point that I would like to make over here is that the medullary interstitium contains plenty of solutes such as urea, and these solutes are hyperosmolar. The hyperosmolar medullary interstitium pulls fluids and electrolytes from the loop of Henle into the medullary interstitium. So there you go, you can see fluids and electrolytes being pulled from the loop of Henle into the medullary interstitium. When an osmotic diuretic like mannitol is introduced into the circulatory system, it pulls fluid from the cells and the interstitial space into the circulatory system, and this increases the blood volume. The increase in blood volume also extends to the capillaries present in the medullary interstitium. And when this occurs, urea and other hyperosmotic solutes are washed away from the renal medulla. This results in a fall in medullary hypertonicity. The medullary interstitium now fails to pull water and electrolytes from the loop of Henle into the medullary interstitium, and the result is increased urinary excretion of water and almost all electrolytes. Now, the indications of mannitol, which is the most important osmotic diuretic, are in the treatment or management of elevated intraocular pressure and intracranial pressure. So this concludes a very brief introduction to diuretics.